Hello everyone, my name is Mishita Goyal and I'm a cardiology fellow at Wayne State University, Detroit Medical Center. Today I present a case of severe acute aortic insufficiency due to infective endocarditis in a cancer patient managed via a multidisciplinary team approach. The authors have no relevant financial disclosures. For introduction, as we all know, acute aortic insufficiency occurs due to valve abnormalities, most commonly due to infective endocarditis. Although considered to be a true surgical emergency, the timing of the valve surgery may vary depending on the presence of heart failure, neurological complications, and persistent infection despite antibiotic treatment. Here we discuss workup and management of a young patient with testicular cancer with metastasis who presented with infective endocarditis complicated with acute aortic insufficiency. This was a 49-year-old male with history of benign squamous cell carcinoma, status post chemotherapy, who presented with 5 days of fever and dyspnea. The patient was septic on admission, so he was started on empiric antibiotics. CT for PE was done, which showed multiple solid pulmonary nodules concerning for metastasis. Blood cultures were drawn, which eventually came back positive for methicillin-sensitive Staph aureus. The source of infection was suspected to be chemoport, which was placed just 2 to 3 weeks prior to presentation, as the port site was noted to have purulent drainage. The chemoport was eventually removed. On physical examination, the patient was noted to have a decrescendo diastolic murmurs suggestive of aortic regurgitation. A transthoracic echocardiogram was then done for concerns of infective endocarditis. It did not show any vegetation, but severe aortic regurgitation with normal left ventricular size suggestive of acute aortic regurgitation. A transesophageal echocardiogram was then done, which showed tri-leaflet aortic valve with flail right and non-coronary cusps and torrential aortic regurgitation. Holosystolic flow reversal in the descending aorta was also seen, suggestive of severe aortic regurgitation. Cardiothoracic surgery was consulted and initially recommended no urgent intervention and CT head to assess prognosis. The patient did not have any focal neurologic deficits observed on examination. CT head showed scattered hypodensities in deep cerebral white matter and left middle cerebral peduncle. Telemetry did not show any arrhythmias or heart blocks throughout patient's hospitalization. After multidisciplinary team discussions and concern for septic or thrombotic emboli versus metastasis to brain and lungs, it was decided to proceed with aortic valve replacement with left atrial appendage ligation given the early stage of cancer and ECOG performance score being 0 prior to admission. Intraoperatively, the patient was found to have an abscess extending underneath the left coronary artery to mid portion of the right annulus. Aortic and pulmonary artery were also adherent to each other. So eventually, the abscess drainage and debridement to normal tissue with bovine pericardial patch repair was done by the cardiothoracic surgeon, along with aortic valve replacement with Carpentier-Edwards aortic valve. This was a very interesting case where the team was presented with multiple conundrums. The patient had developed severe acute aortic regurgitation within 2 to 3 weeks of infective endocarditis, but did not have any heart failure symptoms. Early surgical consultation and multiple team discussions to decide on surgical intervention led to further workup for prognostication and discovery of other sites of metastasis versus septic emboli. The team also had therapeutic dilemma of whether to or not to start anticoagulation if it was a cardioembolic source of emboli, but eventually the team decided to hold off of anticoagulation given increased risk of bleeding for concerns of intracranial metastasis and eventual plans to proceed with surgery. Despite the indication for surgical intervention, the other issue was the risk of surgery and patient viability given his history of testicular cancer with metastasis now. However, Multidisciplinary team approach resulted in successful urgent surgical intervention and post-op care with eventual discharge to home in stable condition. This case summarizes the stepwise management of infective endocarditis complicated by acute severe aortic regurgitation without heart failure in a cancer patient with metastasis. It highlights the importance of multidisciplinary team approach for management of these complicated cases. It also again emphasizes the importance of thorough physical examination, where detection of murmur on admission even before microbiologic test results led to early suspicion of infective endocarditis, followed by urgent surgical intervention, which further led to discovery of aortic root abscess, which could have otherwise led to more complications and mortality. Thank you for listening to me patiently. I hope all of you have a very great day.